Hello guys, welcome back to the next module in the immunology chapter. Here we're going to talk about hypersensitivity. Like I said in the previous module, there are going to be two modules in hypersensitivity. There are actually four types of hypersensitivity. In this module, we'll see about the first two, and the next module we'll see about 3 and 4. I don't want you to have a break in between. Continue it at a go, so maximum an hour or so lecture, and all the four hypersensitivity reactions will be covered, and you'll have a gist of everything required for you. These are rock bottom basics. When we go to systemic pathology and hematology, we'll be reusing the same concept and learning about the pathogens of disease. As usual, if you're ready, put on a big smile and let's start discussing about hypersensitivity disorders. The first and the most important thing, what I want to tell is, I had told in the previous lecture itself that most of the problems of immunity are due to the adaptive immune responses. That's your T lymphocyte and B lymphocyte. Hypersensitivity is an extra reaction, that's all. Extra reaction than it is supposed to be of the T and B lymphocytes. We call them hypersensitive response. Fine. Okay. So these three, 1, 2, and 3, all of them are B cell mediated. Allergy, IgE antibody mediated. Then I have antigen antibody response, that is predominantly IgG, little bit of other things else can also come. And here I have an immune complex. Immune complex is antigen antibody reaction, is a basic understanding, right? So all three are because of problems of B lymphocyte or extra reaction of a B lymphocyte. And the next one here, it's delayed response, and this is T cell mediated or a cell mediated hypersensitive response. Fine. Now, before going into the lecture proper, I want to give a little bit of a gyan, right? So, why is my immune system reacting more? If you look at the entire landscape surrounding you, there are a good number of young kids who are very allergic. Compared to your father, mother generation, this generation and the future generation will be much more and more and more allergic. The answer, I would say, is a very proven hypothesis called an hygiene hypothesis. It said that more hygienic you become during the formative years, that's during childhood, your immune system don't learn much because you are not allowing them to make mistakes. When I say too hygienic, what do I mean by that? Wearing slippers inside home is too hygienic, right? When you were kids, I'm sure you must have gone outside on barefoot and played in playgrounds with barefoot. These days, no, we're not seeing much, right? One, economic state is improved, the awareness improved, so I'm protecting or overprotecting my child. So the child is not getting exposed to multiple organisms during the childhood where the thymus can learn, okay, this is foreign, this is self, this much I have to react. That is one reason which is a common denominator of increase in incidence of hypersensitive response, autoimmune response in the developed nation and in future in India. Again, I'm not saying not to be hygienic, right? I'll be very clear. Hygiene is important, right? Because it will reduce communicable diseases. Hand wash is important. With a hand sanitizer, might not be. Washing your hands and eating is important, not sanitizing your spoon and eating. Wearing slippers outside is important, not wearing slippers inside your home, right? So there's just a thin line between hygiene and too much of hygiene. Let's not go to too much because too much of anything is not good for us, right? So hygiene hypothesis is a very, very approved hypothesis that increased all of the responses. Fine, perfect. Now in this module, we'll look at 1 and 2. The next module, we'll look at 3 and 4, right? So type 1 hypersensitivity, it's also called an allergy mediated or an immediate hypersensitive response. You inhale some allergen, immediately you'll sneeze. That's a type 1 hypersensitivity, right? So here, there are a few features. Is immediate. Obviously, it is immediate after exposure, but there is a pathogenic event called sensitization phase where I won't have an information, where I won't have a symptom, right? It's immediate after exposure to an allergen, but like I said, a caveat, after the sensitization phase, right? Genetically, obviously there is. I'm not going to talk about the genetic link now, but when you go to asthma, we'll more pinpoint and say for this disease, this link. Hay fever, this disease, this link. Allergic rhinitis, different link, right? But definitely there's a genetic link, right? So that's why if your parents are allergic, asthmatic, there's a high probability children might also be asthmatic, right? Because of genetic link, do they both HLA as well as non-HLA antigens, non-HLA genes, right? Mediators here for me is simple. It's going to be mediated by IgE antibody, eosinophils, and mast cells, right? There are obviously few interleukins. We'll look at the interleukins very soon when we go to the pathogenesis. So these are the overall what I have to remember with respect to type 1 hypersensitive response. Fine. Now, if you go to an outline of the response, there's always going to be a sensitization phase. So what do I mean by sensitization? Initial response to any allergen, my body will not react. That is sensitization, right? This is the first exposure of the allergen to the person. Okay, that is sensitization. When I have a re-exposure, right? then is where I'll have symptoms. First exposure, I have no symptoms. Here, the patient will have no symptoms, nothing at all. Nada. Like it will be completely normal. Here, re-exposure of the same allergen will obviously result in a symptom. Okay. But remember, if I'm going to have a second allergen, right? Let's say, for example, pollen grain is an allergen, right? Everyone knows that. And also, let's say I am having allergic to perfumes. Perfume also, for the first time exposure, I won't have a symptom. Only re-exposure will trigger a symptom, right? This is unique for every allergen here, right? But there are possibilities where I can have a response even without sensitization. That's what we call as an anaphylaxis. Even the first exposure might result in a symptom. The answer, why? If this is the routine, it should stick to it, right? Sometimes they don't stick to it, especially when the antigen exposed is parenteral. If you look at any exposure of anaphylaxis, they'll say, drug injection, more dose, right? Inhalation, less. Drug injection, more. Bee sting, directly the venom or whatever the thing is goes directly into your bloodstream, right? Any parenteral route, there's more chance of anaphylaxis than your inhalation route, right? Okay, this is about the outline of how exactly hypersensitivity response happens. But what happens during sensitization? What exactly happens during your re-exposure and what are the symptoms? We'll look at this soon, fine? So here, the pathogens, what I'm going to read here is the same pathogens for asthma. Slight variation might be there, that's all, right? So what happens when the person is going to get sensitized or the first initial sensitization phase? Let's take the same example of a pollen grain. A pollen grain was inhaled in the nasal cavity on the respiratory mucosa. I have something called an antigen presenting cells that will pick up the pollen. I'm writing P for the pollen and it's going to present the pollen to my T cells. These are your APC or dendritic macrophages, like you might know. They are there in the respiratory epithelium, right? This will present the antigen P for the pollen to my CD4 T cells. Okay. CD4 T cells, the moment it recognizes the pollen, it is going to go into your Th1 response. Okay, it'll go to Th1 response. So this, sorry, Th2 response, right? Th1 response for the granuloma formation. This is Th2 response for the allergic mediated problem, right? So this Th2 response will make the Th2 subtype of activated T cells. They will secrete few important interleukins. They secrete interleukin 4. This is going to increase the IgE production by the plasma cells. Okay. Then they will secrete interleukin 5. This is going to attract WBC, and the WBC inward and allergies, you know that for a fact. It's going to attract eosinophil, and interleukin 13 is going to cause epithelium damage, right? It's going to cause epithelial damage, and I'm sure you must have sensed this. Even in advertisement it comes, right? Something allergy comes, some kitch, right? Some amount of irritation will be there in the throat, even the first exposure. Not exact symptom, but there is definitely an irritation, right? So what this does is, this guy is important for me. Eosinophils comes, there'll be a little bit of irritation, not much symptomatic. But what this IgE does is, it goes and sits on a cell we call it a mast cell, right? So we have mast cells here. Mast cells are nothing but tissue basophils full of granules. On top of that, we have your Fc receptor for immunoglobulin, and the IgE sits there, right? So IgE sits there on the surface of the mast cells. That's what is going to happen during sensitization phase. It stops here. There's nothing more there. With sensitization, it stops just there, right? Now let's see what happens if they have a re-exposure. When I say re-exposure, it's re-exposure with the same antigen, right? If there's a re-exposure with the same antigen, what happens is the re-exposure will make, we'll take the same mast cells for an example. We have the mast cell full of granules, Fc receptor, Ig there. The re-exposure makes the pollen, the yellow color is the pollen, binding to the antibody. Antigen antibody reaction will initially cause degranulation of the mast cells. That's enough for me, right? It causes degranulation of the mast cells. The moment it degranulates, it's going to release lots of mediators. Histamine, obviously, right? Preformed mediator. One of the richest sources is your mast cells, right? It secretes histamine, it secretes platelet activating factor. We do have newly synthesized mediator. It secretes prostaglandin, interleukins, prostaglandins, leukotrienes, all of them. And these leukotrienes are going to be chemoattractant, right? So again, be chemoattractant that brings in more new WBCs. It will attract more WBCs, which will cause all the damage left for us, right? So this is what is going to happen, fine? Okay. Now, I'll just add one more page. Just give me a second. So now, let's say all these came. So how will be the symptom? For the symptom part, we divide them into two things, an immediate phase reaction and a late phase reaction. Late is not like after 2-3 days. It's not like that, right? So immediate reaction is by this guy. It's preformed, na? Histamine immediately comes, causes vasodilatation, increased vascular permeability. But this part, leukotriene, going and bringing more WBCs might take a few hours. That's what I call it a late phase response, right? So we divide the symptom into two groups. We call something as an immediate phase response, okay? This happens within minutes, like 5 to 20 minutes after exposure. Very short, right? And might last for approximately an hour. Okay? Approximately an hour, the symptoms last. This is primarily due to the preformed mediators. All the preformed mediators, even a little bit of prostaglandins also do contribute to them. So what happens here? If I'm taking with respect to your throat, I might have a bronchospasm, right? That smooth muscle contraction, and you'll have an increased vascular permeability, might have phlegm, the sputum secretion and everything, right? So it will cause vasodilatation, increase in your vascular permeability. That will cause increase in secretion in the respiratory mucosa, if you're talking about that. And also it causes a little bit of smooth muscle constriction, which is bronchospasm. Next time, if at all you have an allergic rhinitis, carefully watch. Initially, you will have like 10-15 sneezes, your nose will block and everything. After some time, after an hour or two, it will look like it has settled. You'll be like, happy. If you leave it, after a couple of hours, it will start back again. That is my late phase response. So what happens during late phase responses? It starts around 2 to 8 hours post exposure of the allergen. It might last for a couple of days, right? Like any other inflammation, it will be there for a couple of days. This gap, that's where you will feel like I'm okay. But no, it will come back. Why it will come back? It's predominantly mediated by the chemotactic factors. Okay, the interleukin 5, which brought lots of eosinophils. We have leukotriene B4, which will bring lots of neutrophils. So here I'll end up having new WBC. When the new WBC comes, what will happen? Automatically I'll have new granule contents. Automatically I'll have the same symptom again. I'll have nasal congestion, increased vascular permeability, bronchoconstriction, and lots of WBCs will be there in that area. Okay, this is a late phase response. This happens during every type 1 hypersensitivity, an immediate response and a late phase response. Same for asthma, same for allergic rhinitis, same for everything. So what are the examples? Pathogenesis slightly might vary. See, if you have an allergic skin reaction, I might not have smooth muscle contraction here. Obviously, I don't have a smooth muscle in my skin, which is going to cause symptom for me, right? But bronchospasm is very classical if you're talking about an asthma, right? So what are the other examples? If you look at the examples, the major example for me, like I said, it's anaphylaxis. I want you to remember, it's sudden onset. The most important thing is it's without an exposure, okay? It's all of a sudden, no prior exposure. It's a severe reaction. You'll have an edema of airways, might even find it difficult to breathe. The best example for you is bee sting is the best example. Drugs, especially if it's an intravenous drugs or a parenteral route, best example, right? Other examples for allergy, the classical example for allergy, asthma, prototype. You might have allergic rhinitis, will have the similar symptoms, right? The space is different, that's all. Okay, so there's a term called dermatitis, atopic dermatitis. Okay, there are lots of things, urticaria, atopic dermatitis, all of them comes under this, right? These are allergy mediated skin reactions, right? So these are few examples for type 1 hypersensitivity. When we go to systemic pathology, I will not repeat once again. You know the mediators, you know the interleukin, you know the pathogenesis. You also need not read it again. You know the template, please cut, copy, paste there, that's all, fine? That's about type 1 hypersensitive reaction. Now, let's go to type 2 hypersensitive reaction. Even more easier. Antigen antibody mediated. The most common antibody used is IgG. Put a big star mark here. Remember this forever. Any disease going forward in future, in systemic pathology and hematology, if you say that antigen antibody mediation is a mechanism of the disease, most common is IgG. You need not worry about that. Don't memorize, because that's how the disease is. If the template says most common is IgG, if there are 100 diseases under them, predominantly it will be IgG only. Yes, I might have IgM, IgA also, but IgG is the predominant one, right? See, there are three types of hypersensitivity reactions or three pathogenic event. This three pathogenic event is actually based on antigen's location and also the outcome. Let's say, just put a pen down. You have a cell on which there's an antigen, an antibody binds, antibody will be there, and this antibody will go to the macrophage, right? Obviously, because antibody is an opsonin, right? So if it's a cell, I can eat the cell. But with the surface, I can't eat the surface, right? A macrophage cannot destroy a surface. A macrophage can easily eat a cell. But if the receptor, I might not require to always eat the receptor, just block the receptor, enough, right? So based on the location of the antigen, I have three subdivisions of type 2 hypersensitivity. The first one is very simple, opsonization and phagocytosis. Just write one single word here. This happens for free cells. The best example of free cells is RBC, WBC platelets. That's all. Let's say you have an RBC here. On top of that, I have an antigen against which I have an autoantibody. This RBC, when it crosses spleen, spleen has macrophages, right? Obviously, spleen has macrophages. We call them a littoral cell, right? This has on the surface FC receptors. FC receptors is constant chain receptors of immunoglobulin. So this immunoglobulin, which is there on the surface of RBC, will be caught. Along with that, RBC also will be there, where it will be engulfed and destroyed. Okay. So this could be IgG as a covering, or sometimes I can have IgM plus C3 as a covering, or I can have IgG as a covering. Whatever, right? IgM is weak, like I said in the previous module, so it will always ask the help of complement. That also is an opsonin. That also will go in the same route only, right? So ultimately, it's opsonization and phagocytosis if the cell is small and if the cell is free. Easy for a macrophage to do. The best examples, blood cells. The best examples for me is autoimmune hemolytic anemia and ITP. I want you to know the abbreviation. That's why I'm writing the abbreviation. Autoimmune hemolytic anemia. ITP stands for immune thrombocytopenic purpura. Let's stick to the abbreviation. Notes will have the full form, but still let's stick to the abbreviation because that's important for us to understand. Fine? That's one. Right. Now, let's go to the second guy. Second guy is complement and FC receptor mediated inflammation. Now here, let's assume you have a surface. Okay. Let's say this is an endothelium. This is a blood vessel. Just for understanding, let's assume this is a blood vessel. Okay. I'm having here antibody against this surface or whatever it is. Now, macrophage will come here because macrophage monocytes are there in the circulation. They come here, they bind to it. With the same FC receptor, they'll bind. Can they eat the entire surface? They can't eat the entire surface, right? Obviously, it's impossible to eat a surface. So what they do, these macrophages, since they can't engulf a surface, they start to degranulate. They start to degranulate, and that will cause more and more and more inflammation. Okay, that will cause more and more and more inflammation. Okay, that's important. That's why complement and FC receptor mediated inflammation. How will they cause inflammation? Because when they degranulate, they'll have reactoxin species. This will have leukotrienes. This will have complements. It will attract more WBCs, and this more WBC which comes inside is ultimately going to destroy the entire lining of the blood vessels. So kind of it causes an vasculitis, kind of like that, right? So whatever surface against which I produce antibody, I cannot eat it. Rather, I produce inflammation and I destroy it, right? Do you have any examples for this? Obviously, yes. There's a huge group of disease called as an ANCA-mediated vasculitis. We'll read them during vasculitis. ANCA-mediated vasculitis is one. Your acute rheumatic fever, where you have antibodies against the cardiac antigens, right? That is also one, okay? And also you have a disease called Goodpasture syndrome. That's also vasculitis. In Goodpasture syndrome, you have antibodies against collagen 4, right? When you have antibodies against collagen 4, that also is definitely going to cause something, right? These three are classical findings for your type 2 hypersensitivity, opsonization, and FC receptor mediated phagocytosis. The third is even more beautiful. Third, it's cellular dysfunction. I don't destroy here. Why to kill someone if I can remove the plug? Easy, na? That's what it does here, right? It's cellular dysfunction, antibody mediated. The best example for it is, see, I say cellular dysfunction can be more function is also abnormal function, less function is also abnormal function, right? So I'll give an example for each one of them, right? It can either reduce the function of a particular area or can either increase the function of a particular area. Both are dysfunction. This is abnormal, right? So I have antibodies against, okay, acetylcholine receptors. I'm sure what disease I'm talking about, right? You know that, right? It is myasthenia gravis. So when I have antibodies against acetylcholine receptors, it does not destroy the acetylcholine receptors. Let's assume this is my neuromuscular junction. These are my receptors here, acetylcholine receptors. The antibodies go and sit there. When they sit there, they will not let the normal acetylcholine come and bind. So there will be reduced function in the neuromuscular junction. NMJ is neuromuscular junction. That causes weakness in the muscles. I don't destroy the receptor there. That's why when I give a drug, it still can function. Removing the blockage, it still can function, right? One more thing is increased function. So I have something called an TSI. It's called as thyroid stimulating immunoglobulin, right? It's an activating antibody. These are antibodies against the TSH receptors. So what they do is they are thyroid stimulating immunoglobulin. So let's assume there's a thyroid epithelium, right? There's a receptor for TSH here. This antibody comes and binds and this will activate the receptor. So what do you think will cause? Hypothyroid or hyperthyroid? Automatically it causes hyperthyroidism, and that's the best example for Graves' disease. Actually, we saw two subtypes along with the two examples also. Graves' disease, myasthenia gravis, both of them are antibody-mediated cellular dysfunction, right? That's the third type of type 2 hypersensitivity. So we know three different types of type 2 hypersensitivity, and also we know one classical finding in type 1 hypersensitivity, right? That brings to the end of this module. Like I said, the same no break. Go back, hit the next video, complete type 3 and type 4, then we deserve a break. Till that, no break, right? See you soon. Till then, bye bye from Dr. Ranjith. Bye bye. Go back soon.